Hi, my name is Bree, and I'm going to be presenting on the medical terminology present in the disease state diabetes mellitus. Actually, before I begin, I want to share a little story about how I keep straight diabetes insipidus differentiated between diabetes mellitus. So mellitus actually has the Latin word root that means honeyed or sweet, referring to the sweet urine that diabetes patients urinate out. Insipidus means untasty, and it refers to the fact that there is no glucose in the urine of diabetes insipidus patients. Diabetes mellitus is the type of diabetes that you're probably very familiar with and that you've heard a lot about because it's the common type of diabetes. Diabetes insipidus is a disease state where there is polyuria, a lot of urination, but it's from the cause of increased antidiuretic hormone, which is also known as ADH. So, the prevalence of diabetes mellitus. It is extremely common in the United States. About 34.2 million people have diabetes. 7.3 million of those are undiagnosed, which is why it's so important to understand the medical terminology of the disease, because you may run into a patient that has all these symptoms of diabetes and is unaware that they are putting themselves at risk at developing complications and having an early death. 10% of people who have diabetes have type 1, and 90% have type 2, which is probably the type that you're more familiar with. In type 1 diabetes, it is known as independent diabetes mellitus. It is known as insulin-dependent diabetes mellitus. That means that the amount of insulin is what is affecting the disease. It is caused by cellular-mediated autoimmune destruction of the pancreatic beta cells, and it usually occurs in children, but it can occur in adults as well. The destruction of the beta cells occurs years before symptom onset, and when the symptoms do occur, they are abrupt because there is no insulin present, meaning that all the glucose is staying in the blood vessels. It is not getting absorbed. And it is caused by an HLA-DR gene mutation. That HLA locus on DNA is responsible for a lot of autoimmune diseases. And type 1 diabetes is considered to be an autoimmune disease because your own body is attacking itself. In type 2 diabetes, it is known as insulin-independent diabetes mellitus because no matter how much insulin you have in your blood vessels, you are unable to absorb glucose. Your ability to absorb glucose is independent of insulin in type 2. This type oftentimes develops later in life. The increased blood glucose levels leads to increased insulin production, and it continues to elevate until your body stops responding to insulin in a positive feedback loop. So as you can see in this diagram here, insulin is the triangle and glucose is the hexagon. Insulin is present in type 2 diabetes, and it's binding to the insulin receptors as it should. But these insulin receptors aren't activating the GLUT4 receptor, which is what absorbs glucose through facilitated diffusion. Because of that, the glucose is remaining in the blood vessels and not being absorbed by your tissues and is not being used as an energy source for the body. You can see here that these beta cells are what are destroyed, leading to a complete lack of insulin. Here, there's insulin. In type 2 diabetes, there are environmental and genetic components. If you have a family member who has type 2 diabetes, you are more likely to develop it, but there are ways that you can prevent it, and that's by the environmental factors that you have control over. In gestational diabetes, the pregnancy hormones estrogen, cortisol, and human placental lactogen create a contra-insulin effect. That means that they're blocking the insulin from working. And this actually happens in most females who have a pregnancy. You have these hormones that are blocking some of insulin's ability to help you absorb glucose. What makes it gestational diabetes is when your body can't overcome that blocking effect. Your body will naturally produce more insulin, but if you're already pre-diabetic or you have a lot of the risk factors such as obesity or high-weight babies and a history of high-weight babies, then you're much more likely to develop full gestational diabetes. Some of the complications of gestational diabetes are macrosomia, hypoglycemia. So in macrosomia, large macro, means that the baby's going to be very, very big and it's going to have a lot of adipose tissue. The reason for that is that the mother's blood vessels are filled with glucose. So the baby has access to all this glucose from the mother's blood. And the baby is able to produce its own insulin. It's doing fine. So it is absorbing all this glucose and depositing it into fat tissues, also known as adipose. Then when it's born, it no longer has access to all this blood glucose. It doesn't have access to the mother's blood. So what happens? It still has all this insulin going around. It bottoms out and the baby no longer has hyperglycemia, so it has hypoglycemia. It does not have enough blood glucose because it has too much insulin. This is the normal physiology of glucose uptake. Postprandial, meaning post-meal, you would have increased blood glucose. That blood glucose is going to travel around your body until it travels through the pancreas. And once it gets to the pancreas, that's going to signal for the pancreatic beta cells to release insulin. That insulin is then going to travel around the body and bind with insulin receptors. Once it's bound to an insulin receptor, that insulin receptor will then activate the GLUT4 receptor to bind to glucose. And then glucose will be absorbed into the cells through facilitated diffusion. Then the blood glucose will decrease to normal levels within 2 hours of the meal. Now in type 1, the pancreatic cells are destroyed, so they are not producing insulin. But in type 2, there is insulin flowing, it's just not activating the GLUT4 receptor. Symptoms of diabetes, type 1 and type 2 are very similar. The biggest difference is that in type 1, you have abrupt symptom onset, and then in type 2, it is much more gradual because it takes a long time to become resistant to your own body's production of insulin. Symptoms are polydipsia, which means that you are very thirsty, polyuria, frequent urination. So if you're urinating a lot, you're not able to absorb as much of the water that you're intaking, meaning that you are going to feel a lot more thirsty. You are going to have a lot of increased hunger, or known as polyphagia. And that's because you're not absorbing the nutrients from your food. You're not absorbing that glucose, that building block of energy that your body needs. So because of that, you're going to be a lot more hungry. You're also going to be losing weight, and it's going to be unexplained. You're not going to be changing your diet or your exercise routine, and that's called cachexia. You're going to be fatigued, blurred vision, slow healing sores, and frequent infections, along with hyperpigmentation, and that means darkened skin, and it oftentimes occurs in the back of the neck. Complications of diabetes is diabetic retinopathy, which is when you have damage to the vasculature of the eyes, causing damage to your vision. There are two main types of complications. There are microvascular, meaning happening in the very smallest vessels, and macrovascular, which happens in your larger blood vessels. In microvascular, the main one is diabetic peripheral neuropathy, DPN, which is when nerve damage occurs because of the microvascular damage. Oftentimes patients report feeling numbness or tingling in their extremities, especially their feet. And then in macrovascular, the main one is peripheral artery disease, which occurs when there's constant vasoconstriction of arteries, and that leads to tissue damage. The leading hypothesis is that insulin, the increased amount of insulin in type 2 diabetes, causes blocking of nitric oxide forming, and nitric oxide naturally dilates blood vessels. So your blood vessels are much more constricted because the increased amount of insulin is blocking the nitrous oxide. The tissue damage can result in ulceration, so a lot of foot ulcers, and then they can get so bad that they can lead to amputation, and then that tissue damage is also what's causing the retinopathy. Funny enough, the diabetic peripheral neuropathy makes the peripheral artery disease worse, because when you can't feel your feet, you're not aware that an ulcer has formed. And then that ulcer is going to become worse and deeper, and then you're also more prone to infections, and it's going to become infected, and then it'll become so bad that there's literally a hole in your foot, and their only way to solve it is through amputation. That happens in a lot of diabetic patients, so primary caregivers often do monofilament or vibrational tests to see how bad the diabetic peripheral neuropathy is, and to also do foot checks to look for ulcers. All right, so the risk factor for developing diabetes mellitus type 1 is the presence of the HLA-DR gene mutation, and there is no way to prevent symptom onset. For type 2, it's a lot of risk factors. There's family history, obesity, inactivity, age, and race can all play a race in the development of type 2 diabetes. Luckily, in type 2, there is a way that you can prevent symptom onset, and that's by eating a healthy diet, exercising, losing weight, especially in the abdominal region. Studies have shown that when you have excess abdominal adipose tissue, it puts you at risk of heart disease and diabetes. And then you should also, of course, avoid being sedentary. Being active can release a lot of hormones that can help with insulin sensitivity in the body. For treatment, there is overlap between type 1 and type 2, but in type 1, because they cannot produce their own insulin, the focus is on introducing exogenous insulin into the body. And unfortunately, you cannot take oral insulin because your stomach acid will destroy it. So it has to be injected or placed into a pump that uses a catheter into your abdomen, or surgically implanted devices that release insulin. For type 2, they typically start with oral medications that stimulate your body to either react to or produce more insulin. Examples of these would be metformin, decreases the hepatic production of glucose, so you're not putting as much glucose into your blood vessels. Glitazones actually increase your skeletal muscle sensitivity to insulin, and then sulfonylureas stimulate the pancreas to release more insulin. All of these can really help with decreasing blood glucose. If your blood glucose is still elevated after trying these treatments, then your doctor may prescribe injectable insulin as well, in addition to your current treatment. Obviously, all of these drugs have different contraindications, and every patient is going to need a different cocktail of medications in order to keep their diabetes in check. The best treatment for diabetes type 2 is actually going to be a healthy diet that is low in glucose, and then exercising. Losing weight will not cure diabetes type 2, but will remove symptoms so much so that oftentimes patients can come off of their current medication regimen. All right, and that's all I have. Here are my references. Thank you guys so much, and have a great day.